সবাইকে মিউট করে দে।
Welcome everyone to the first webinar of West Bengal Orthopedic Association with AOTS on proximal humerus fractures. So we are very happy and delighted to organize this type of webinar first from this part of the country, from West Bengal Orthopedic Association. And we have got very eminent panel of faculties and panelists, and we'll be discussing very interesting cases.
To the first webinar
and first, to start our program, first we'll request our President Sir, Professor Chinmay De, to address us before we start our scientific session, followed by our Secretary of West Bengal Orthopedic Association, Dr. Partho Sarkar, will be saying few words before we start for our scientific session. So to Professor Chinmay De, sir, please say a few words.
Good afternoon, members of WA and IOA and other state branches if they are present. This is, as already told, this is the first webinar. We are stuck at the home and it will continue up to 3rd May by this time, you all know. So this time should have a proper and quality utilization. That is why we have started. It is thanks to Dr. Swarnendu Samanto. He has initiated the program, and now we have made a committee, expert committee, Arnob, Ritik and Rajiv being the chairman. We will organize in a proper way, and we have, I expect, we have lots of program on different subjects today onwards. And you all know this is this day, 14th April is the, in Bengali it is the New Year's or Subon Awards to you all. With few words now, I request Partho to take over. Partho.
Yes, sir. Subhaman Navabarsha, but not good one. It is a difficult time. It is a great pleasure to welcome you all on behalf of West Bengal Orthopedic Association as a part of organizing team. First of all, I must thank you whole team, especially our President Sir, Dr. Professor Chinmay De, for his wholehearted support, and the specialist faculties, Dr. Samantu, Dr. Gigi Kaur, Dr. Somito Mishra, Dr. Aish Chatterjee, and our panelists, Dr. Rajiv Raman and other Sunit Hajra and others, and our young energetic moderators, and above all, our participating member for making this first webinar of West Bengal Orthopedic Association. On behalf of West Bengal Orthopedic Association, I will try my best to continue this webinar, especially for young postgraduate students, and we will try to organize different national level webinar also. And that again, I thank you all for your patience hearing. Arnav, please continue.
Thank you, President Sir, our Secretary Sir. And so I invite now our eminent faculty, Dr. Swarnendu Samanto. He will be discussing and carry on the scientific discussion with interesting cases. So I ask and request everyone to please join, stick to us. It will be very interesting one. So to Dr. Samanto, please. Sir, you can start.
Yes, just 1 minute. I'm trying to share the screen.
Okay, sir.
Okay.
Can you see the screen?
Yes, sir.
Hello.
Yes, sir. Yes, sir.
Yes, can
Yes,
you see
sir.
it?
It
Okay,
is visible, sir.
Okay, so I welcome all the learned faculty, and this is a great honor that Professor Chinmay De, who is currently the president of West Bengal Orthopedic Association, and also my younger brother Partho Sarkar, who is currently the secretary, and for their support we could make this event. And this is the first webinar from West Bengal Orthopedic Association. So I welcome all the learned faculty and we have collected the cases from the learned faculty and we'll discuss one by one. So this is the case, 36 years male, fall on the outstretched hand, right shoulder injury. It is a fresh injury. On the day of injury he has come. No distal neurovascular injury is there, presents with this X-ray. So my question to Soumitra, Dr. Mishra, how you go ahead with this X-ray? Hello. Hello. So Dr. Mishra is unmuted.
No,
Yes, now I unmuted you.
Yes.
Now, can you hear me?
Yes, yes.
Yes, unmuted.
Again, muted. Or no, please unmute him.
yes, he's unmute. Yeah, sir, you can speak.
So,
now,
Yes.
what do you have any sort of only one X-ray satisfied you, or how you go ahead with your X-ray?
no, that's the point. This gentleman has presented a proximal humerus fracture, which you can see pretty obvious from this X-ray, but this is not a proper view. So I would like to do proper X-rays for the right shoulder injury. What you do for a trauma patient, there are usually 3 views we do. Which is if you go ahead one slide, then I can discuss it further.
Okay. So Rajiv, do you have any, Dr. Rajiv Chatterjee, do you have any, you are satisfied with any X-ray of the AP, or do you always have, go for your true AP? What is your plan?
It has to be a true AP and a true transcapular lateral view.
So you need 2 X-rays.
At least 2 X-rays.
So Achilles, always you take what 2 X-ray?
At least 2 X-ray, one axillary and one AP.
You
most
go
of
for
the time.
You go for the axillary.
Axillary and AP, because most of the technician not able to do the scapular lateral view.
Okay.
So in that case, I have to go to the X-ray room. So I usually advise axillary lateral.
That I'll come. Dr. Amitabh Narayan Mukherjee, he has one of the pioneers of the country in shoulder surgery. So please unmute him. I will listen. Please unmute him, Dr. Amitabh Narayan Mukherjee.
Am I audible?
Yes, yes, you are audible. You are happy with the AP X-ray, or you take another any X-ray?
Definitely, the other X-ray, glenoid view or Y view is required. But today's scenario, if patient can afford, I will go for an further imaging. If patient can afford for before.
Okay, that I'll come later.
But otherwise, glenoid view and Y view is also sufficient along with an X-ray, true AP, because that will give you more.
Professor Kaur.
Yes, most of the AP views are not proper AP views of the glenohumeral joint. That's the AP view of the patient. Unfortunately, the scapula is rotated about 30 degrees forward, so the AP view for the patient is not AP view for the shoulder joint.
Okay.
So I would basically I have taught my own radiologists where I work to take how to take a proper AP view and axillary Y view in an injured patient, in a fractured patient.
Okay, okay.
But unfortunately, that's not possible everywhere.
Okay.
Sometimes patients come
So
with access to us.
you rely on the AP and the scapular Y view, or you take AP and axillary?
Sorry, again? AP and Y view?
You rely on the AP X-ray and the axillary, or AP of the Y view, axillary?
Y view is not an axillary view. I would advise the axillary view, that is a Velpio view, okay, which is least painful to the patient, and this AP view of proper inclination. You are showing this here.
Yes. How to take the proper AP?
How to take the proper AP view? That is a 30-degree internal rotation.
Okay. I'm coming. So your proper AP. You Soumitra, please. How you know that this is a proper AP?
Yes, now we can see on the left hand side that the humeral head and the glenoid are not overlapping. So you have, as Jijida said, that scapula is a 30-degree anterior angulation. So we need to correct that angulation. How do we do that? We just angulate the patient at 30 degree to the X-ray cassette and take an AP view. So that will prevent the overlap. If you just
Okay,
click
okay.
one, Shananda,
Okay.
just click one. So you can see the right hand side. That's not a true glenoid AP because here the humeral head and the glenoid are overlapping with each other.
And
So
one more
that is
thing.
Okay.
One more thing. If even after the 30-degree rotated view, there is a significant overlap between the glenoid and your humerus, then you think about subluxations, posterior
Okay.
subluxation, anterior subluxation.
true.
Okay. Okay. Dr. Professor Kaur, just tell in short how you train your technicians to take the transcapular or the Y view.
Okay. Books are there, your pictures are there, and sometimes I call them to my operation theater. There is a C-arm, not only for the shoulder, but for different other joints and other bones also, different special views, because if you show them in C-arm, then they will readily capture what is to be done. They are experienced, only they need some prodding. Okay.
Okay, so Dr. Hajra, Sunit, do you take this X-ray only or AP or the hot X-ray, axillary view, bell view or the scapular Y view?
I think if I am doing a X-ray, then I'll probably do an view, I mean axillary lateral view. But if most of the time, where if I'm planning to get a CT scan, I usually don't get an X-ray.
Only AP.
That's
Yes.
Rajiv,
That's
you do
what
the,
I said.
Rajiv Chatterjee.
Yeah, I agree with Dr. N. Mukherjee, sir.
Rajiv.
I am very selective with my CT cases. My patients unfortunately can't afford that much. Anyway, just jokes apart, I think these two X-rays give us a very good idea regarding a geometry of a reasonably non-complex fracture.
Okay. Okay. Moving ahead. So, do you anybody in the faculty? Okay. Okay, Rajiv, continue.
Just one point is that very simple to train your radiographers. Just tell them the rule of 30s. A rotation of 30 degrees outwards in both sides. That's it. It's so simple. And it's very less traumatic. There's no pain if you're doing a transcapular Y view. Axillary view, you can cause a bit of pain to the patients.
Okay. Do anybody advocate this sort of X-ray in trauma scenario? Anybody in the faculty?
I won't.
No.
It is
Okay.
it is difficult. The lying
So,
down is very
painful.
So message is clear. So Mitra, what is the message then for the viewers?
It can be done in a standing position also.
It can be this sitting and standing that can also tolerated, but lying down this position is very painful.
So Mitra, what is the message then for the X-ray?
I think the true glenoid AP and a scapular Y is good enough to give you a lot of information.
So you don't. So we don't support this sort of X-ray.
Yeah, axillary lateral is difficult, painful, maybe in other situations, but in trauma situation, it is difficult to do and it's painful for them.
So basically, you want to have this AP, classic AP like this one, and the Y view. Okay. So Somit, yes or no?
Sir, there is a comment on YouTube.
Yes.
Do you need to clarify that? The comment is like that we don't need the true AP view of the shoulder. Rather, we want AP view of the proximal humerus in external rotation. So, do you need to clarify it or?
How could one have an? Come on.
Thing is that basically in a trauma scenario, you never do an external rotation. External rotation with your back. It is painful. Rather, you external rotate the torso to 30 degree to the cassette, and you just shoot directly front to back, front 90 degree to the your cassette. Obviously, we'll get the more or less nearly like it to the scapula. So that the thing is that your scapula should be parallel to your cassette. So that is the trick.
Yeah. Because if you, in a fracture like this, if you do an external rotation, the proximal humerus has no control. So
basically in the AP and your transcapular, this Y view, we can get the fragments even.
Yeah.
And you can make an undisplaced fracture into a displaced fracture.
Yes, that's what I'm saying.
Because
by rotating the
So these are two X-rays. So I will request Dr. Sunit Hajra. So there are two different X-ray. For these two different X-ray, you need CT scan or you choose yours. How you write your CT scan?
No, I think these are giving reasonable opinion regarding the fracture geometry. So I will probably not get a CT scan for this patient, but probably most of the proximal humerus displaced fracture where the GT is fracture, I think it's better to get a CT scan to understand the fracture geometry better.
I will rather ask CT scan for the second patient. May not be for the first one, but
First
for the
one means the
second.
left one. Any comment from any faculty? Any comment?
Left one, but for right, I will ask for a CT scan. Right, my second one.
That means where the head is varus. So you will the left one. Rajiv, your opinion. Rajiv is quite expert in this proximal humerus. Rajiv.
Wherever I have the reasons where I do a CT scan would be wherever I'm trying to assess a small head. How big is my head to whether I can fix it, or is there a particular split? These are the two absolute indications which I see. We have just our AP here with a proper transcapular Y view, even in the right hand side one, we can make out how big the head is. Is there any doubt of a head split? These are the two situations where I would definitely do a CT.
Yes, that's sort of the thing. So there is a head split.
So that means your threshold. So your threshold for ordering a CT scan is very less. All panelists agree
it's very high. It's very high. I wait a lot. I mean, I think I can get all my data to a certain extent from a proper AP and a proper transcapular Y view. If in doubt beyond that, with the articular or the head fragment size and combination, I would get a CT.
We would also take into consideration the magnitude of the injury. If it's a osteoporotic ground level fall, standing level fall, then probably there is no need for a CT scan, probably. And if it is a high velocity injury thrown out from a motorcycle at 60 kmph, probably then there's an increased chance of head splits, your impactions, and your subchondral combinations. In those cases, probably CT will be.
So I think Dr. Amitavanan Mukherjee was quite right that probably for the left one, even there is CT scan, the displacement is much less on only the GT one, but the varus fracture one is really the varus one. So you get a lot of information.
In fact,
Achilles, your opinion, when you operate in proximal humerus fracture, every time you have the CT scan, or do you have the choice on that?
No, sir. Just 2 to 3 view. Just I want to make on X-ray. If I fail to plan on X-ray, then only I order for the CT. Because as you know, I am practice at a small town. So ordering CT every time is not possible for me. So I want to gather more and more information on X-ray. But even if I not clarify myself how to do, what to do, then I order CT.
So this is the X-ray. This is the CT scan. Even you can see the 3D CT scan. Anybody can take this case. Anybody. So I think Sunit, you take the case. How you will plan? Sunit?
No, I think I need other information as well. Age of the patient, activity and dominant side and everything.
Yes, this is the non-dominant side. Patient is 50 years. This is the fragment. Fresh injury is not old one.
But a high velocity, probably.
Yes, obviously. And distal neurovascular is okay. He has come on day one, just the morning he has fallen, and he has come to in the evening clinic. You have done this investigation. This is there. What is your plan?
I think I would rather, if it's a 50 years old person with reasonable activity, I would rather try to fix this.
Fix this is what?
Fix with proximal humerus locking plate, Philo's plate.
Rajiv?
Agree with him there with the proper tuberosity reconstruction, because here just worries the tuberosities.
Okay, Gigi, Dr. Kaur, Professor Kaur.
Yes.
Professor Kaur, you are going to fix it with what?
Before that, I would like to have a axial cut to ascertain that there is a sufficient amount of head is there without a split.
Yes.
Because in these 3 views, I am not sure that there is not a head split. If there is no head
before that, you want to be sure there is no head split.
Yes.
Okay. So that
because
is
the counseling will also be different by then if there is a head split. And in this case, there is no medial hinge. There is maybe 2-3 millimeters of calca remaining with the head, and there is displaced, and it is displaced. So there is a high probability of vascular necrosis in this head also.
Yes.
Okay.
That's what the point I was coming, that in this case, I would like to have a backup of replacement in my head. ME, I will keep.
In 50 years, how you go with the replacement?
At
No,
50
no.
years.
I
50
said
years,
when
50 years.
no, I am not saying that you replace it. I said the backup. You keep in backup. It is a case for fixation. But many a times when you open up, you cannot.
But 50 years, who is the other faculty who is going with Dr. Mukherjee to replace it, even there is a split in the head? Rajiv, your opinion? You will try to reconstruct?
I would try to reconstruct.
Achilles?
Yes, sir. I will reconstruct. There is a three problem in that. One is the small head fragment. Other it is valgus impacted, and valgus impacted sometimes behave better. So I will go for the osteosynthesis in this case.
So
In fact,
Achilles, you have opened a Pandora's box. Thing is,
Swarnendu,
how you classify your valgus impacted in knee
Not valgus infected. The head fragment is basically in valgus.
Okay. So what classification you follow for head this valgus impacted?
So no classification. Just we follow the geometry of the head. Here you have
Needs classification. Yes, it's there.
that is the age-old classification, but inter-observer variability are so much there. So AO classification has less inter-observer variability, but the geometry is more guiding me than the any classification.
Okay, Soumitra, can you throw some light on this valgus impacted fracture? How you classify in your practice?
In knee classification, there is a very little information about the valgus impacted fracture. So valgus impacted fracture as AO classification has taken into consideration the valgus impacted fracture. But
this one you are referring to?
Yes, the 11C2 is the valgus impacted fracture. But in knee classification, there is no particular definition about or description about the valgus impact. But that is a very common fracture we see in our practice. So that is one of the weak point of the knee classification. But again, coming to AO classification, which is also very extensive and it's difficult to remember. Rather, knee classification, you remember, remembrance is a little easier.
Do anybody follow the Hartel one? Anybody in the faculty?
Yes, I do.
Yes, Hartel criteria done.
Simple. It's a simple classification.
Very simple. 4-block system. So it's very simple.
Achilles, do you follow this?
No, sir.
Sunit?
Yes, sir, I do.
For what? Head split or what?
Yeah, no, I mean, this is mostly for an assessment of the vascularity. That is the main criteria, Hartel's criteria for the vascularity. That is more important than particularly this block classification.
So you go with these three things?
Yeah.
Swarnendu,
yes.
In Hartel's classification, there is nothing called a head split because you see in all the pictures, the head fragment, which is the top one, always in one fragment. Okay. It is either separated from the GT or LT or shaft, but there is no head split in the Hartel's classification.
Yes.
Yeah, that was the shortcoming of Hartel's one.
Yes, this is the problem with this thing is that in Hartel classification there are only 5 combinations.
Yeah.
But after the extension of the Hartel classification, this has again joined with the Hartel classification. Is it 13 and 14?
Yes.
So in the Hartel classification, 13 and 14 is the head split.
That
So
is
that is extended Hartel. Swarnendu, that is extended Hartel cut.
Yes. Dr. Gigi Kaur, Dr. Kaur, your opinion on this head split on Hartel?
Yes, this is the modification which is very required.
Okay. So so Dr. Hajra's opinion is that you take this length of the metaphyseal thing, integrity of the hinge and the fracture pattern, the positive predictive value for the Hartel. So
yes, definitely, sir. I think if you found an head which has a metaphyseal beak of around 7 millimeter probably, and or the medial hinge is intact, I think you can go ahead and have a reasonably good prognosis regarding the head ischemia is concerned. So, but in the last case which we saw in the 50-year-old, even those criteria was not meeting. But even then, probably most of us would like to do some sort of fixation in those sort of situations as well.
So this is the case. This was said by Rajiv, tell.
Just one little point here. In a young patient, even a avascular head, because it is a non-weight bearing bone, can be very asymptomatic. I have a couple of them whom I fixed has gone to AVN now 15 years down the line. They are quite asymptomatic. So even if they go into AV, unless there is collapse with the screw penetration, they are quite asymptomatic.
Okay.
That's general observation.
So I think this is Rajiv, you have to present. This is your case.
So the 65-year-old lady, she's diabetic. She's a homemaker. Basically does what we are doing today. So you know how much of work you have to do.
We cannot see the X-rays.
Can't see the X-rays.
No, we can see the X-ray.
Yeah,
we can see the X-rays.
Yeah,
Acha, you're seeing on a phone view. I think he's seeing on a phone view. Put a laptop will be easy. Anyway, so she's this non-dominant side. I see her 2 weeks down the line. What would you think? How many to sort of go ahead, have a CT scan now?
Who is for CT scan? Please raise your hand.
Put your hands up.
Put your hands up. Who is for CT scan?
No hands up.
Ornob is there for CT scan.
Okay.
But I cannot see the X-ray.
So you have to come to the laptop. So next,
okay,
Rajiv.
Get up. And then basically what would be, so what is the next plan? How many of you would fix it? She's 65. How many would you replace it? How many of you do something else? So fix it. How many of you fix it? Put your hands up.
Those are for the fixes, sir. Please put your hand up.
So I can't see in apps. Shawnee, I'm just seeing 3 people. So I don't know, it's not expanding.
No, Rajiv has joined. Rajiv Brahman, you are welcome.
So how many would...
Professor Pal has also joined.
Yeah, Professor Pal has also joined.
So how many would replace it?
Who is going to fix it, or who is going to fix it? First take the vote like that. Rajiv?
Yeah, so how many? I can just see 3 people on my screen, unfortunately. I don't know what's...
There is a scroll down button. There is a scroll down.
No, I just tried that. It's not happening. I've got a very bad internet connection today.
Okay.
Okay, so how many would... let me just drag it out.
No.
So, okay, they can tell you who is for fixation.
How many for fixation? No, okay. How many for one fixation? How many replacement?
Replacement me.
Fixation, nobody. How many would conserve it? Just wait and watch.
On myself, I will go for conserve.
I will also go for conservative.
Okay, Shomitra, why? What is your point here?
Now see, this is a 65-year-old lady, diabetic, left hand, maybe non-dominant hand. Yes, non-dominant hand. She has got appears to be an impacted fracture. Tuberosity is not separated, and I will clinically examine and see about the stability between the fragments. And I think I find it reasonably stable and moving together. So I will go for conservative.
Sunil, what about the medial side? The hinge.
The medial side, I think, although it's the break-in, but I think it's rather impacted. So probably
yes,
lateral
stable.
hinge is also, stable sort of
it's a
fracture.
stable impact.
Lateral hinge is intact, and plus the medial side also there is impaction. So I would like.
Okay, 6 weeks. 6 weeks, patient asymptomatic. So, okay, so starting from Shonilda, I think I'll pick on you. So what is your protocol? If you're treating conservatively, do you put a plaster on them, or do you put them in a splint? What do you?
I will never go for a U-slab or any sort of plaster. I don't want to take the pain to. I don't want to add any pain to the patient. Just don't give. Even I don't give the shoulder immobilizer. I just put on the plain sling. If it is impacted, the message should be clear to the viewer. That is only the plain sling will do the trick. If it is not going to the plain sling, nothing else. The plaster or your shoulder immobilizer is not going to do. Only don't lie on that side. And when you lie, at least to keep 2-3 pillows so that you are comfortable.
I think one more thing is, if you are seeing an impacted fracture, you need to see it on both the views. That fracture is really impacted. It's not actually on the other view. It might be displaced posteriorly or anteriorly. So that you need to, ensure it that the fracture is really impacted inside the head.
Okay, that we discussed. That we have to have both the X-rays to whatever you do.
So what would be coming to Arnav? What would be your mobilization protocol for this patient?
So after 3 weeks, we'll start the mobilization. We remove the bag and we'll start the mobilization gradually, abduction followed by the rotation exercises. Before that, the elbow, wrist and grip strengthening exercises. So I think we'll start up around 3 weeks.
Anybody differs from this?
No.
Rajiv Raman,
I am. No, not at 3 weeks. in conservative, hello, am I
Yes,
audible,
yes,
Dr.
yes,
Rakesh?
yes,
yes.
Yeah, no, not 3 weeks. If you do it after 3 weeks, there is the inevitable stiffness. So even for the first 5 to 7 days, just you allow pendulum exercise or whatever comfortable to that. After 10 days, you repeat the X-ray, and after seeing the X-ray, see the stability of the fracture. If you think the fracture is stable, fracture is not moving, then again you start physiotherapy some more. Generally 2 to 3 exercise. Then after 3 weeks, we start more exercises.
Rajiv, your opinion. Rajiv Raman. Rajiv, your opinion. Rajiv, when you start your exercise?
Normally, I start the pendulum exercise after 2 weeks, and one thing I do, I put a 500-gram cotton here to keep the limb a bit of abduction, so that and tie it with a stockinette. So it's an abduction.
Oops, it's gone off. Okay, Jijida, anything different?
No, nothing different.
Okay, so we all agree that it should be with the shoulder sling. Rajiv, what is the message for your case?
The message from this case is the conservative
abduction sling.
Okay, abduction. You would start abduction.
Stockinette, abduction sling. And before planning for conservative treatment, I think it's better. I agree with Soumitra that take the patient to the OR and see in CR where the whole of the fragment is just having a movement, a globular movement or not, and then plan for conservative treatment. Because most of these impacted fracture, if you go for 5 or 10 days external internal rotation to see the whole of the proximal fragment is moving with the distal fragment, then you can quantify it. You can tell that yes, it's an impacted fracture and can be treated conservatively.
Okay, so Rajiv, please summarize this case, Rajiv.
So basically,
can I add a single point?
Yes,
that's what that is just everything is fine, but I just wanted to add that so far stiffness is concerned, it is in practice in UK. Soumitra must be knowing it nowadays also that vitamin C for fracture distal radius and proximal humerus, they really work well to prevent this sudex and stiffness.
Okay, well, that is a different subject, Amitabh. We'll talk on that on some other day. So, okay.
Okay, point taken. So I just did a little research on this mobilization protocols, and basically what the current recommendations, what I follow too, is as soon as pain subsides, start rotation pendulum, basically just pendulum Codman's exercises. As soon as pain subsides, within 5 to 7 days, start off and abduction, which is non-active, assisted for the first 3 weeks. After 3 weeks, gentle assisted active exercises. Exercises only after 6 weeks. So
okay.
that's.
So can we go ahead, Rajiv?
Carry on, please.
Yeah.
So this is the next patient. How many would like to fix them? Fix this one.
Who is for fixation? Who is for fixation?
Put your hands on fixation.
Professor Paul. Professor
yes,
Paul.
Yes.
This is 70 years old. Rajiv is representing social life.
Somebody is walking. It is very difficult to hear because is the 2 or 3 persons talking with simultaneously. It is very difficult to.
No. It is not side talk. Side talk. You are probably.
I am hearing Rajiv's voice. Rajiv Chatterjee's voice.
Yeah. Rajiv, you present the case.
Yeah, so basically, just to bring the point that this is another impacted fracture. Two things I look at the fracture when I'm conserving. Number one, what is the level of impaction? Number two, where the tuberosities are. Where the tuberosities are separated or riding high, those are potentially.
Yes, sir.
Number two is take a serious, get them mobilizing. After mobilization, take another X-ray in 2 weeks. If stays in the same position, that fracture is going to unite and can be treated conservatively. As you see, just go to the next slide. Do you have the clinical pictures?
Yes, these are the clinical pictures.
Get motion like this. So you select your cases properly. Selection cases, again, repeating tuberosities in position, not flying out, not separated, head impacted, either varus or valgus, but not dropped off, not too much of combination, articular surface intact, large head, non-dominant hand, not high demand patient, comorbidities, you can treat them, but take an X-ray at 2 weeks after starting pendulum and active exercises. Don't keep them immobilized. That is my point.
This is the final X-ray.
Yeah. Sir, I would like to add something.
Yes.
Carry on.
Sir, in valgus impacted, it behaves very well in conservative management, in elderly especially, sir. Sir, anything you want to say? Valgus impacted, we have very well in elderly patient. So it should be conserved.
And as long as it's not displaced the tuberosities, the key is the tuberosities. The tuberosities are flying out, that is potentially unstable. You have to have the sleeve around which the head has to sit. So don't look at the head and shaft alone. Sorry, carry on. Next.
Achilles, your
Sir,
case.
one
Yes,
minute.
sir.
Before we go to the next case, there are a few comments and clarification which is needed in YouTube comments.
Yeah.
So for conservative management, whether only arm sling or shoulder immobilizer?
Arm
Only
sling is enough.
Only arm
Arm
sling.
sling is enough.
Only arm sling.
And when to start the movement?
That we have
As
already
soon as pain
elaborated.
subsides.
That we have already elaborated.
I've just given you steps of mobilization.
And also there has been a comment regarding the X-rays when you treat these fractures conservatively. So do we have to, especially in older patients, do we have to look for any changes of avascular necrosis in the head? X-ray changes.
That you cannot know within a span of 6 months time. You have to get some. Now the thing is that we have to have the X-ray just to have the follow-up that the fractures are not displacing. Professor Paul, you agree on that?
Most of the fractures where the conservative treatment is usually planned, where the displacement is not good, I think you know that the probably chances of avascularity in those fractures are really less. So I think it's very difficult. So you don't need to look at the.
Okay, we have to go ahead.
Yes,
Achilles, please, your case.
Yes, sir. Sir, this is my 65-year male patient having hypertension, diabetes, and history of CVA 1 year back. But this arm is not paralyzed. This is normal limb. So he has fall, and at day 1 he came to me. So I will ask the panelist how to proceed. Sarnendu sir, for you also.
No, because ask the other faculties because I have.
I think I would like to ask Dr. Rajiv sir would like to do a CT scan on this or not?
In this one, yes, definitely. I cannot, as somebody pointed out very well, the 2 X-rays, if you cannot do a plan, get a CT. Here I can't plan. I don't know how big the head is. I don't know if the head split.
Would you like to have 2 proper views or CT scan? Which one is?
Go for CT scan because even these 2 views I can't make out.
You agree that if you are planning to get a CT, there is no need for any further X-rays?
In this case, your situation where the head is, the size is unknown, looks like the head split, the tuberosities are split and fragmented, go for a CT.
So everybody agrees on CT scan?
Yep.
Yes.
So all panelists agree on CT scan?
No, okay. I would rather say that CT, maybe you have an MRI to see the attachments.
That is 65-year male, sir.
Why MRI?
It's 65 years, sir.
I am just listening because I cannot see the X-rays. But as I am just drawing.
Okay.
Amtoda, why don't you go to a laptop?
So,
sorry, go back.
Achilles, this is the next one.
This is the next one. So, as this patient was not willing for any kind of operation, so he also not proceeded for any kind of investigation. So again, I was forced to do conservative management. But one thing was that in fracture, you can see there is the valgus impaction was there. So I have also not forced patient to go for the operation. So I have started the conservative management, and this is the X-ray of the same patient after 12 weeks. And this is his range of motion after 3 months, because he has already many illness. So that's why he was not ready for the operation.
So basically, you support this even for this fracture conservative treatment, all the panelists?
No.
Maybe yes, but I think with proper trial, I think you can gradually moving more and more towards the, conservative treatment.
Professor Kaur
is prepared to accept some degrees of loss of frontal elevation and scapular plane and coronal plane abduction. Because if the greater tuberosity lies higher up than the head articular surface, then there is bound to be some loss of abduction. If the patient is okay with that, and if the patient does not want operated, then this is basically the side effect of not properly reducing the tuberosities. So if the patient is okay with that, I have no quarrels with that.
Professor Pal?
Yes, actually, I think it should be operated. The operation would be ideal because see, the greater tuberosity is remain displaced, and that is the cause of this restricted movement. The patient is just doing this scapulothoracic movement. I
Yes,
think
yes.
the glenohumeral movement is grossly restricted, I think, and ultimately that may cause pain, especially on the overhead activities.
So
Is the
panels
If the
discuss
patient refuses operation, then he have to accept. He has to accept this loss of function.
Yeah.
So recommendation is that we all recommend that this should be operated.
Yeah.
Yes, sir. But sometimes elderly patient with multiple comorbidity, they do not want further operation.
No, if the patient doesn't want, that is a different issue. But the recommendation should be operation. If the patient doesn't want, he cannot do anything.
Can I just add a point?
Yes, Rajiv.
Just add a point. He's at a CVA on the other side, isn't it?
Yeah.
So this is his more important arm. So we are actually incapacitating him having both arms incapacitated.
No, CBA, but he is not hemiplegic. He has history of CBA.
Fine. Just point.
Rajiv, your opinion, Rajiv Raman?
Yeah, I will definitely operate in this case, but as Akhilesh told, the patient was not ready for surgical option. But one opinion, Dr. Rajiv Chatterjee, sir. So, whether scapulothoracic movement, if you fix this fracture also, how many of your patients will have what amount of most of the range of motion you see? If you fix also, the majority of range of motion is scapulothoracic rather than glenohumeral. Because you fix this fracture.
No. If you fix this patient and start a good fixation with a good tie down of the tuberosities properly, you get at least 120 degrees, 110 degrees of glenohumeral and 30 degrees of scapulothoracic. So you get 140.
So what is your recommendation, Rajiv, for this case?
For me. Yeah. For this case, I would go number one, a CT scan to look at the head fragment. If the head fragment is not split, I'm still worried if the head is split. If the head fragment is not split, I would go ahead, fix it with a good tie down the tuberosities. I would spend nearly 45 minutes with the tuberosities, getting the tuberosities right with 3 or 4 ties in the tuberosities, get them together.
Okay, we're moving ahead. Just 1 minute. This is the fracture. This is the arrow is given there. The patient is 74 years, lady, fresh one. I will come to Professor Pal.
So
yes, now I can see.
Yes, actually, Dr. Amitav Mukherjee, I think he will support me. Actually, I have seen several cases in this scenario. See, the older patients, osteoporotic, grossly displaced fracture at their 2-part or 3-part. So there may be very large comorbidities will be there. When anesthesists basically they insisted me just only half an hour maximum we can give that, they will give the anesthesia, nothing will be given. So that is why this is the case. So either you have to accept the conservative management, either there is no option, that is we have to go by supervised neglect. See what is happening, the whole head is completely rotated, we can see here, and there is some there must be some tuberosity. Tuberosity is the overlapping shadow of the tuberosity, and see the medial displacement of the shaft because of the pectoralis. So there is severe, and there are some patients, you see the hands also there. See the position of the hands, the shadow of the hand, because there are some chest pain also there. In that case, the patient is so painful, so patient have to do something no conservative management, either in the form of the arm to chest strapping or by the universal shoulder immobilizer.
How we are going to fix it?
That is I'm telling. So in that case, you have to give by the minimal invasive technique. Actually, I learned this technique from Dr. Mukherjee, Dr. Amitav Mukherjee. So this is the very, very useful technique. So I think Amitav will recall this. So, yes, it's just little bit modified, but almost this is his idea. So this is the basically this is a 3 sorts of K-wire, and this is basically threaded K-wire, and this is not actually reported till now, and there's only very 2 or 3 studies are already published till now. So there are what will be done, that is actually the first reduction. Reduction should be done by indirect methods. Either if that is completely rotated, in that case, so you have to derotate the head with the help of the joystick, either putting a 2.5 millimeter, 3 millimeter K-wire, and then first reduction. Then the first set of K-wire to make the shaft to the head, and second set of K-wire from the above down, and another set of K-wire from anterior to posterior. So 3 sets of K-wire. Can you see the next slide? Next slide.
No, this is not the other case. So do you have any complication? How many wires already you have told it? How to manipulate already you have told it.
Yes, suppose those cases which is already treated conservatively before, and those cases we treated by this method, and it's a very excellent excellent maneuver. And actually, complication, paraoperative complication, there is only one. There is a breakage of the wire tip, because sometimes we have to push very obliquely. So in that case, with 1 or 2 cases, there was a breakage of the wire, and this is not my case actually. There is one case.
No, this is not your case. This is a different case.
Yeah,
Soumitra, do you have any experience on this migrated K wires ever in your life?
Yes, I have quite a few of them. I have removed one, removed one from neck actually. One has gone into the supraclavicular fossa. I removed K wire from there. I removed K wire from axilla. So yes, to start with, I have done a few of them, but I really do not endorse this procedure anymore.
Can I speak something?
Yes.
Yeah.
Can I?
Okay. So I will come to Amitabh.
This is a technique which I started modifying the. Can you hear? Hello.
Yes.
Am I?
We can hear
This
you.
is a technique which I started modifying the American Academy. American Academy, they put cannulated screws on the top of. They put 3 axially: lateral, medial, and anterior medial. The American Academy, this is a standard procedure by putting cannulated CC screws. And after that, I modified, but I had this breakage of K wire in complication, and another complication which I had is infection. If you have an infection in this, then it is really bad. I had, unfortunately.
Professor Paul, you please present this case. It is yours.
Yes. There's a patient is 55 years old female with history of trauma 7 days back. There is a fall on slippery surface. There no other injury to no distal neurovascular deficit. In echo, this is a very significant. That is, ejection fraction is only 39%. There is a high risk for major surgery. Okay, so that is why. See, this is the radiograph. This is now I think this is another case. This is another case. Yeah, this is another 65 years old female. 3 days old fractures. This is multiple comorbidity, Perkinsonism, and with significant osteoporosis. This is the X-ray of this. I think it is upside down. So this is the radiograph of the right humerus, and the left radius. Same patient, right humerus is this, left humerus, left radius is this. So this is the case. Next one. Just before going to that,
take the opinion of the house, how they are going to treat the humerus.
Yes.
Professor Kaur.
About this pinning of the proximal humerus, there are 2 or 3 standardized methods. Okay, 2 or 3 standardized methods. One of them, can I share my screen, laptop screen here?
No, then it will be difficult.
It will be difficult. You can come back. Okay. So the trick of not having these pins migrating here and there, we follow that. We use link joints from your just set, and through those link joints we pass a bent at the operating table itself, a null rod. Okay, so that null rod connects all those external ends of these outer ends of these K wires in a bridging fashion. So it prevents migration of the K wires, plus it bridges all those K wires into a stable construct, more stable construct.
Anybody in the faculty is for J's and K wire? Anybody?
So I would like to conserve the proximal humerus. I think if you look into the proximal humerus part in the inferior X-ray, it looks that the displacement is minimum, and probably that is the lateral view. And in the AP view, relatively, if you can take that as an AP view, with a little bit of valgus, if you can accept it. So I think probably I would like to go for conservative for the humerus, as this is a very compromised lady with 39% ejection fractions, and the distal radius also I would like to.
The previous case was 39%. This is not.
Okay. This is not only Parkinsonism.
So I did this.
I think this can be managed with Jess, with what we used to do, Anando.
Yes,
I think
so this is done. In this case, this is the first set. I have fixed this. This is the second set of K wire in this, and the third set K. And as Dr. Gouda just described, the same thing is done. Same thing is done.
We We always
Yes.
do it from the day one. From the day one, we fix it up with
So
this.
there is a no point of migration of the K-wire inside.
Yeah,
There's no point. So if the K-wire has to migrate, this link joint should go inside the skin. This is not possible. Okay.
Yeah, yeah.
And not only that, the whole see the just a minute before radiograph, just before, yeah. See, these K-wires are bent. So there is a whole construct. There is the axial compression between this K-wire and this inferior K-wire. This one. Then the second compression. All the K-wires are compressed. There is axial loading.
Preventing tension.
Yeah, preventing. So that is, there is no question of loosening of the pin, and there is no question of migration of the pin. Only one pin, this anterior pin is only the non-threaded, because that is the pin where this is given in a very inclined way, and this is the pin which is the high chance of that is a breakage at the junction of the thread and the smooth part. So this is the only pin. And
Anando, can I ask a question?
Yeah.
Now, Anando, now why you are not fixing this structure by a Philo's plate? That's my question.
That can be done. Yes, just it is required only 20 to 25 minutes operation, and at the both the sides.
You are worried about the medical complications, anesthetic complications.
Yeah. Medicine,
so now in that case, I think what Proffer trial has guided us that all these fractures can be treated conservatively. So why not conservatively? Because this process, this technique is not without complication.
Yes, that can be done. See, but see the functional. Yeah, you were right. We're right in. I'm not going into opposite to your. That can be done conservatively. But see what is happening. Patient is moving hard. Their activities both the limb from third day onwards. See, show the next slide. Yes, the third day onwards. This is a non-spanning radio. Non-spanning X-fix is done on the that side, so the patient can move his all activities as heaving, feeding, that is dressing. Everything can be done. This is not possible if we do the conservative, isn't it? Say the radiograph at 4 months follow-up, patient is absolutely normal activities. Even the Philos can be almost equivalent results. So I think I am very much satisfied. I have done almost over 150 cases inspired by Dr. Mukherjee, actually.
Anando, we should publish it. We should publish it.
Yeah, I think
indication for doing something.
And if we consider the Dr. D.D. Boxi's case, I think it's over 200 cases.
But
okay, so this is an option, but
K-wire as such, I mean, percutaneous K-wire are usually recommended in the young patient with good bone stock. And
that is why I'm showing this. That is showing
older patients with poor bone stock. So I think
you are right.
Okay, move ahead. So this is the 4 month of the distal radius.
One.
Yes, Rajiv, your comment, Rajiv Chatterjee.
See, if you look at this lady at 4 months, she is doing on the right side. There's definitely restriction as she's using a lot of scapulothoracic motion. The problem with pins, quite often, what happens is causes fibrosis of the tracts. Remember, these pins are tethering the deltoid and as you know, you're going through the rotator cuff, you're going through deltoid. So a lot of soft tissue scarring also happens, which you need to take into account.
But doesn't have, yeah, you're right. But
let me just finish.
Just go the previous radiograph, previous clinical photo, previous.
Not radiograph. I'm talking about the X-ray,
previous clinical.
See, she's the way she's lifting it.
See this range of motion is almost 160, 70. So they are
a conservative gives the same one. A conservative management in my case, the ones that we all showed before.
Yes, I have already told. If the conservative
we all agree that JS is a good option in expert.
Another option.
But it is a good option. But thing is that putting the K-wires, manipulating in proper position and taking the C-arms, and you have to have the real good excellent surgical skill like Professor Pal and Amitabh Narayan Mukherjee. Otherwise, it is
we'll come to you for training.
Yeah, because it is a difficult surgery. It is not K-wires are not very
simple. It's very difficult. It's very difficult.
So this is Soumitra, all yours, Soumitra.
Now we have discussed all about conservative treatment, pins and wires. Now I think we should move ahead for fixation with plate. Now this is a 65-year-old retired gentleman, right hand dominant, right shoulder injury. Now does the panelist agree that he is otherwise a fit person, no medical comorbidities? So does the panelist, do all the panelists agree that this fracture needs internal fixation?
CT required or not? Rajiv, can
100%
you?
CT is not required, but it is a 60 members. If you want to internally fix, then philos can be done in this case. The
We have already discussed that CT is required probably in most of the situations.
CT discussion already were done. Rajiv Raman, your opinion, Rajiv?
Yeah, I will do CT in this case, definitely.
You will do CT and you will fix with what? Fix with what?
Philos plate.
Philos. Everybody or philos?
CT দেখে বলবো।
CT দেখে বলবে। Oh, CT দেখে বলবে। আচ্ছা, very good. Soumitra, go ahead.
Now, if you plan to fix, then what is your preferred position? The
Beach chair.
Everybody beach chair?
No, I think I do it in supine with a little bit of elevation of the upper part, not typically beach chair.
So can we take a vote? Who goes for beach chair and who goes for supine?
Yeah, beach chair is beneficial because that will help to rotate the C-arm.
Yeah.
Almost all of the screw penetration, especially which is occurring in the inferior aspect as also in the posterior aspect.
Anybody else for beach chair or supine?
This is a beach recliner, I think, not a beach chair.
It's a rather declining rather than beach. It's a beach chair is rather more vertical.
The position is fine. Semi-beach chair is position fine. For a full beach chair, there is always a possibility of cerebral hypoxia and
absolutely.
So this position is fine.
Dijita, what do you prefer? You prefer in the beach chair or in the supine position?
Exactly the position you have shown, the semi-beach chair, beach recliner.
Semi-beach chair. Nobody does in all of us use that. Anybody does in supine position?
Yeah, I usually do in supine position.
My position is also similar to him. So when I told him that it's just a little bit of elevation of the upper part of the torso, I think. So that comes down to like that only.
So basically, it is not like the rotator cuff sort of 70-degree beach chair is like 30-degree inclination.
It's 45 degrees. This is
45 degrees sort of. So Mitro, how you
so coming to our approaches, yes. Preference of approaches for the panelist. What kind of approach do you decide on the fracture geometry, or it's you have one particular fixed approach in your mind and you do all your cases through that particular approach? Sunit, what is your preferred approach?
I do 99% case in deltopectoral approach.
Swarnenduda, your
for this particular fracture and for 99, it's not like 99. Most of the fracture, unless this can be done with a very little manipulation, then only I go with the superolateral approach. Otherwise, all my approaches for proximal humerus is classic deltopectoral.
Rajiv?
Yeah, deltopectoral. Except when you see in your X-ray or CT scan there your greater tuberosity lying far laterally, then only I prefer the deltoid splitting or lateral approach.
Okay. Rajiv Chatterjee?
Tried all the approaches. I think at the moment, if there is not much of a varus tilt, if it's a reasonably valgus fracture, large head, then I do a split deltoid, which is the lateral approach. If not, a medial combination, varus drop down, where I have to do a lot of work, deltopectoral.
Jijida, your preferred approach? Dr. Jiji Kaur?
Yes.
Your preferred approach for fixation?
I'm not audible, I think. Okay.
Now you're audible.
Yes, deltopectoral.
Always? All your cases?
Not always. This X-ray, you have shown this X-ray for this particular patient.
But so you do also split deltoid?
I do also split deltoid, yes.
Anando?
Yeah, 99% is a deltopectoral, unless Dr. Rajiv said, that is, if there is some issues to reduce the greater tuberosity, it is older, and then in that case, you have to split deltoid, and with that is only case. Otherwise, if there is a fresh case also, but there is no significant displacement at the surgical neck is almost reduced, and in that case, minimal invasive technique you can use that deltopectoral. That is the two.
So what you can find that most of the panelists prefer the deltopectoral approach for most of their cases. So this is a kind of workhorse for our proximal humerus fracture fixation. Now you all know this particular approach, the incision. So you need to get to the right interval between the deltoid and pectoral. Look at the cephalic vein and find the interval and go. Once you go into the interval, then it's all easy. Swananda, we should add something, or
you have written like how to protect the axillary nerve. Do you need something for the axillary nerve to take care during the deltopectoral, or is more likely for the superlateral?
I think for the deltopectoral approach, because whole of the deltoid is retracted laterally, so axillary nerve goes underneath because it is very closely related to the inner surface of the deltoid. So once you retract the deltoid, the axillary nerve is automatically protected. For the other split deltoid approach, you need to be careful about protecting.
Okay. I'm coming to one point because there is a question that they are asking, when you dissect in the deltopectoral groove, do you ever change your adduction or abduction or some way to protect the axillary vessels?
No. 45-degree abduction to just relax the deltoid. Not for the axillary nerve, because axillary nerve not come in the deltopectoral approach.
Absolutely. Yes.
See, axillary nerve pathway as it comes from the back gives off its major branch to the middle fiber deltoid from the posterior itself. As it winds round to the front, it's just with the anterior. It's already given its last branch off. So, but the deltopectoral approach actually cannot damage because the last branch has been given off.
Soumitra, you can ask any faculty how they do the superlateral.
Yes, now I can see most of the faculties are in preference for the deltopectoral. Anybody want to take up and describe the minimally invasive MIPO approach for the proximal humerus or split delta approach?
Yes, I have given few cases also. If it is there, then I have both minimal invasive and anterior lateral approach photographs also. So if you open my
okay, we'll come there. We'll come there. This is just for the discussion sake we are coming. So when you what is your
I can describe anterolateral approach. What is shown here? Most probably this is anterolateral approach. What I am seeing there is the straight line incision from the anterolateral border of the acromial. This one.
And how far do you go now? So okay, let's come to this case. Then I can discuss this approach further. Here.
Okay.
So this is a 42-year-old male banker, right hand dominant, no comorbidities, and distal neurovascular is normal. So anybody want to describe this X-rays? Particular type of fracture? What is this?
Diastema on the cone. Valgus impacted with this pressure.
Valgus impacted, separated tuber, separated tuberosity. Now, if we talk about the valgus impacted fracture, now as we have already said, and Akhilesh has nicely mentioned that valgus impacted are relatively stable kind of fracture. Now, they do very well, they unite very well. So, what kind of angulation you look at? We know about some angle called the cervicodiaphyseal angle, CCD angle. Now, what kind of angle we are looking for, that where you decide on your fixation for the valgus impacted fracture? Anybody?
In valgus impacted, CCP angle is almost more than 130. And
no, normal CCD is 135 degrees. So it should be more than that. Yeah.
So in valgus impacted, it is more.
How much valgus you can take?
I don't think any literature is there for the how much valgus you will accept. There is literature for the varus, 110 degrees the cutoff for the varus. For the valgus, I don't think any literature is available. How much valgus?
Ajib Chatterjee,
there is literature support is there. Primarily like 170 degree up to take, but nowadays the theory is that you cannot go beyond 165 degree.
Yeah, 160 is the cutoff value.
160 degree is the cutoff mark. Yes.
So better to remember, if it is 135, the normal angle, you can go on either side 20 degree.
30.
Okay. And the other important point is when the head goes into valgus, the GT separator and GT goes high up and posterior. So that's the major concern for disability if we allow to the GT to heal in that position.
Can we move
yeah, please do. So that's the CT scan. You can see it's valgus impacted fracture and widely separated tuberosities, and probably the part of the head is attached to GT as well as LT. So kind of head split maybe. So I would like to ask the panelists, what will be your surgical approach for this?
Basically, we are asking who is other than the deltopectoral.
Me.
You
okay.
Yeah, because because in delto, the disadvantage of the deltopectoral is that especially the greater tuberosity, the visualization and manipulation of the greater tuberosity is very difficult. So that's why the newer approach, that is called the anterolateral approach, come in the market. And in here, you can mobilize the greater tuberosity better than the deltopectoral approach. And as it is valgus fracture, so through that window also you can elevate the valgus fracture also. So
okay,
anterolateral would be.
We got your
yes, sir.
Rajiv Brahman, your approach?
Deltopectoral, because see, it's not widely displaced. You can just address this greater tuberosity with deltopectoral approach also. And
so your approach is deltopectoral for this case.
Yes.
Professor Kaur?
Yes, for this
your approach for this?
Again, DP.
DP. Rajiv, I know that you will be going with the DP. Rajiv Chatterjee.
Yeah, you see the lesser tuberosity. Lesser tuberosity is lying in front, just below the coracoid. Can you see that?
Yeah.
Yes.
It's very difficult to get to the lesser tuberosity from the split deltoid approach or the anterolateral approach. So the new thing that I have learned from John actually for these cases is I just show it. I do it like that. So I get a draped arm table at the side and I just swing it in and out. So just put the arm in full abduction and you can really go behind and bring your tuberosity out. That's the main problem. Your tuberosity lying back. You can bring your tuberosity out quite easily.
Okay, can I move ahead, Soumitra?
Yes. I think this particular type of fracture, I venture on the MIPO technique because, you know, if in this particular approach, you just straight away hit the head once you open the subdeltoid bursa. Now, going a little bit detail about this particular approach, as Akhilesh mentioned it, we need to understand the location of the axillary nerve. It's about 6 centimeters below the inferior margin of the acromion. Just go back a little bit, one slide back, and 3.5 centimeters below the tip of the GT. That's the normal anatomical location of the axillary nerve. So that you need to put a mark there before you make your incision. And your incision starts at the anterolateral margin of the acromion and goes straight down. You know where your axillary nerve is, and once you have split the deltoid, the raphe between the anterior between the anterior and the middle head of the deltoid, you just pass your finger inside and palpate for the axillary nerve on the inner surface of the deltoid. Then you will see the blood fill the subdeltoid bursa. Once you open that subdeltoid bursa, you are right onto the fracture. Now go ahead. So now once you have opened that area, you need to take control of the tuberosities with your sutures through the GT as well as LT. Take double sutures on both the LT and GT. I think we all do that regularly. Sutures to the supraspinatus above, infraspinatus and teres minor behind, and in front of LT with the subscapulary sutures. Now, once you have taken control of the sutures, then you go straight into the head and you need to disimpact the head. Now, the beauty of the valgus impact fracture, the medial hinge is intact. So that's the area where the head rotates along with that. So go ahead, Fernanda. So once you have elevated the head, then you need to take control between the shaft and the head. So you pass a couple of K-wires from the shaft. Now here you need to take care of the location of your plate, because so that your K-wire should be rather start from the anterior entry, so that when you are putting your plate, it doesn't hinder your plate position. So you do percutaneously from the anterior part of the shaft.
Are you putting the K-wires percutaneously or through the window?
Percutaneously. From the anterior surface of the humerus. Now there is one thing, once you elevate the head, there is an area of bone loss. Now you need to assess this amount of bone loss there, because if it is said that if the bone loss is more than about 15-20 cc area, then you need to augment the area with substitute. But nowadays, rarely with these locking plates, we are using bone substitutes. Anybody use bone substitutes for this particular type of fractures or bone graft?
No.
Because valgus
No,
impacted
no,
fracture
in
once
osteoporotic bone, obviously, yes. Yes. In
because
osteoporotic bone, yes.
valgus impacted fracture, when you disimpact the head and come into the normal sort of CC, the angle, then the problem is that there is a big void. Do you agree on that?
Absolutely, yes.
So in osteoporotic, probably you sometimes need bone
Osteoporotic, yeah, you have to use some bone grafts or bone substitutes.
that is the
I think
classic
this-
variety.
And I think 41 is relatively young patient.
Yeah, I think, but for elderly patient, I think we should have some provisions for keeping bone substitutes or bone grafts. Because if the void is too much, then it's very high chance of failure, even if you fix it nicely.
Can you move forward?
Yes, please move forward. So once you have taken control of the shaft and the head, then you take control of this tuberosities. You can put one caveat to the tuberosities. You can see. Then you position your plate and pass your tuberosity sutures through the plate. Then fix your plate with the head and shaft. Now here the question of putting which screw first really doesn't appear because if you are trying to reduce your shaft to the plate, then normally we try to put the screw through the shaft first, then the head. But here you can do either. Take proximal and distal control. And once you have a reasonable proximal and distal control, you tie the tuberosity sutures through the plate hole. I take a double suture, so I put one suture through the hole and then one sutures on the plate. Go ahead, Sananda. So that's your definitive fixation. Now, I must admit that there is one disadvantage of this particular approach. That's why I normally do not recommend this for a varus displaced fracture. One disadvantage is that it's very difficult to put your calcaneus screws through this approach. Very difficult. For a valgus fracture, probably not that important. Though I managed to put one calcaneus screw through this in this particular fracture, but in most of the situations, it is difficult, very difficult to put your calcaneus screws because your axillary nerve comes into that particular area where the screw holes are there. For varus fractures, these calcaneus screws are very important. So it's better you do not try this approach for varus displaced fractures.
Can I ask?
Achilles, yes.
Can I ask him a question?
Rajiv.
Yes.
Yeah. You said about there on the CT scan looked like a lesser tuberosity had flown out in front. If the lesser tuberosity is also broken out, is it easy to get it through this approach? I have struggled. That's the reason I'm asking you.
No, it's not very difficult. If you just rotate the arms and then you can see anteriorly, you can actually get hold of the lesser tuberosity.
In this case, it was attached to the head, luckily. But the lesser
yes, it's attached to the head. Yes, but I agree. But it's not very difficult. You just rotate your head and internal and external, then you can get it control of the.
We have to move a bit fast, otherwise we won't be able to carry the cases. So this is Achilles' case. Achilles, you can present you can ask the panel which is still now what is not been touched, particularly that question you asked.
No, the mainly this is the varus fracture. So I will go for the OT in this case. Even she is 55-year dominant and there is no comorbidity. So I have opted for the operation. But which approach? That is the main question to the panelists, to the faculty. So which approach I should go? Deltopectoral or anterolateral?
Amitabh Narayan Mukherjee. Professor Kaur.
If further imaging does not show any fly out as Rajiv has described of the tuberosities, then it is perfect to go with a deltoid split. Deltopectoral is perfectly okay also, but you can have a minimally invasive approach of deltoid split. If the tuberosities are more or less in the place, which is evident in this particular X-ray, but I'm not sure about that.
Yes, sir. There is some undisplaced line at the GT. Otherwise, it looks like two-part fracture.
Displaced will be easily taken care of by percutaneous fixation first. Okay.
So it is almost two-part fracture. So next slide.
So you can go for NIPO. You can go for formal.
Sir, this is the lateral view of the patient.
Yes. Even then. Tuberosities are not
completely. Tuberosity is not fracture. It is.
I've got a question to you.
Yes, sir.
How you could get this lateral?
Sir, because in spite of some pain, patient during X-ray they cooperate. So it can be taken in the fractured arm also.
No, this X-ray was taken at the PLS, and then patient was referred to the Achilles.
Oh,
No, sir. It is taken
of the PLS hospital, that how we take the proper X-ray and send it to Achilles.
Achilles.
Can I move forward?
Yeah.
Yes, sir.
So already we have discussed this. Already we have discussed.
Yes, already. So in approach we will go. So what I would like to describe this approach. This is the anterolateral approach. So as the Soumitra sir has said, the anterolateral approach, although it is the virus, although there is the dislocation, but it can be managed through the anterolateral approach also. Only thing is that in your way this is the axillary nerve will come in your way. And for this approach, what we are choosing, there is the interval between the anterior third and posterior two third. There is almost a raphe, and through which raphe we have split the deltoid. And as you can see, the axillary artery come from back to anteriorly.
No.
So yes, sir.
Axillary nerve.
Axillary nerve from back posterior to anteriorly, and in this approach, only 1/3 of the axillary nerve come in your view, and that is separated, through one catheter, and then after the reduction of the fracture, just glide the plate through it. And sometimes I open, do not go through the MIPO technique. I open usually whole length, as you can see there. And there is the compression for the deltopectoral approach. In deltopectoral approach, you are more anteriorly. So that's why axillary nerve is not came in your way. And you can see this has been done, and that is the intact axillary nerve. That is axillary artery is also there, and sometimes it starts bleeding. So you should also be prepared for that.
Branch of axillary
artery is not there.
Branch of the axillary artery, sir. That is the veni committentis.
You are asking.
Yes, sir. Veni committentis.
Yes.
So you should try as thick as possible to keep it. As the Soumitra sir says, there is very difficult to put the calcar screw. You can see here, I was not able to put the calcar screw because even of opening this, your calcar screw will come at this axillary nerve. So during drilling or during placing your jig, there may be damage to the axillary nerve. So that is the disadvantage. But with some manipulation, you can give calcar screw also. So that is the X-ray of that patient.
Yeah.
Yes, sir.
This is the post-operative picture you are taking now.
Yes, sir. This is the post-operative picture of the same patient, and that is the incision from the anterior border, and this is the function. After around 6, I think you can see the faint scar also, and you can see the anterior border of the deltoid. That is the intact.
Okay. Nice presentation, Achilles. Any opinion from the faculty? Anything somebody is doing differently? Rajiv Raman is point.
Now, just one thing, one question with Rajiv Chatterjee, sir. So, whether it is important to keep just 3 centimeters of sleeve doing a MIPO, why not to just do it like this? Because whenever I am doing deltoid splitting, I just make a long incision, axillary nerve is in front of me, just keeping a 3 centimeter sleeve and doing a MIPO. Do you advise that, or you advise just doing a long incision and seeing the axillary nerve and put your plate underneath?
So basically, because you can palpate the nerve quite easily and slide the plate below it. So why do you want to fiddle around with the nerve? Even traction injuries can happen with that nerve. As you know, dislocation, shoulder traction injury, you can have a nerve palsy. So number one, what I do is I put a stitch at 6 centimeters. So my incision does not come beyond the stitch. All my work is in that area. So my indication would be a valgus impacted. I do not varus fractures through this, the large tuberosity. So mainly it's the tuberosity work that I'm doing there. Then you slide the plate below the nerve, you have less amount of soft tissue dissection. You have less amount of scarring. Axillary nerve traction is less. Deltoid scarring is less. When you split this deltoid like that, even rapid, there's scarring. You try to avoid the scarring. That's it. It was wonderful job, Akhilesh.
Yeah.
Great,
Okay,
fantastic job. If you do it in MIPO, the scarring is less.
And Rajiv also. I mean, Rajiv Chatterjee also.
Yes.
See, the advantage of having a lateral approach, I mean the deltoid splitting approach, is that it's a MIPO. Okay, minimally invasive thing. If we have to give a long, if you have to make a long incision and expose the whole length of the plate going through the soft tissues, burying the axillary nerve, then I think it's better to have a deltopectoral approach, because we are not dealing with the tuberosities, especially the inferior part of the greater tuberosity in this fracture. So it is better to have a deltopectoral approach rather than endangering the nerve in any sort of way. If it is a nerve, if we go for a full incision, then it is better to go for a deltopectoral approach.
So Mitro.
Yes.
So this is your case. Can you take that?
Yes, yes. Now coming back to the case we showed before for the patient positioning. Now this is a 65-year-old male patient, retired, right hand dominant, right shoulder injury. As we all agreed that if this patient needs a CT scan. Swananda, please show us
this is all they get. CT scan and beach chair, semi beach chair sort of 30 degrees. This is the CT scan. Who is for Jace and who is for Philos?
Philos. No Jace.
No
I'll go for training. I'll go for training. I need training.
Training under Akhilesh or Anando?
Akhilesh, I think I know. Anando is definitely. I'll go. I want to see it. I want to learn. Definitely.
So this is, as I said, that my preference for a varus displaced fracture is a deltopectoral, because I need to get my calcus screws at the right position. That is sometimes that is my first screw for this particular type of fracture. I need those screws in the perfect position. So, if you look at the first picture on the number 1 picture, the maneuver is just opposite. You need to elevate the head. Head normally goes posteriorly and into varus. So you need to correct that and then again take a control between the shaft and the head. You need to consider your plate position, because that is very important. Because later you found your K-wires in the wrong position. They need to open it and you create a lot of mess. But before that, as for every case, we need to take control over the tuberosities. That's a must. So you need to have 3 sutures superiorly, anteriorly, and posteriorly, and a pair of sutures for each. So now once you have reduced your head to the shaft and the tuberosity is controlled, then the job is easy. Just putting the plate and take control of the proximal and distal fragment. Here sometimes the shaft is displaced medially. In that case, you may have to use your shaft screw first as a reduction screw. One important point which you have not discussed before is the plate position, where you are going to position your Philos plate. Ideal location is about 5 to 8 millimeter below the tip of GT and 5 millimeter behind the bicipital tendon or by a bicipital groove. Why? Now, if we do not put it, if we put it higher, then the plate will impinge in abduction and forward flexion. Now, why 5 millimeter behind the biceps tendon? The ascending branch, can you go back, Sananda, a little bit? The ascending branch of the anterohumeral circumflex artery, which is a very important vessel for head vascularity, which lies very close to the biceps tendon. So I tend not to disturb the biceps tendon from the groove. Sometimes it is dislocated, fracture because of the fracture it gets damaged. But if it remains intact in some fractures, I tend to leave it in that position, because so that I do not do any damage to the ascending branch of the anterohumeral circumflex artery. So you understand the position of the plate. Now then continue with your fixation the same manner, and your tuberosity sutures get good hold of the tuberosities as all the faculties mentioned with pair of sutures.
Okay,
yes.
Thank you, Soumitra. So this is another one case, 49 years. This case came to me, with this, so I will show you the X-rays with this sort of fixation. Do anybody is doing this sort of fixation anyhow, or do you recommend for this fracture? Anybody in the faculty?
Yes, I will do it. I'll do it.
You will do it
with a new, with a
multi-lock.
This is not multi, this is old type of.
This is not multi-lock.
Old type of nail.
No, this is
the old type of no.
This is multi-lock. I know the multi-lock. This was before the multi-lock. This was done this way. Do you have somebody has experience on this? Or do
Yeah,
you
yeah, I have used
That
this.
once I did this nail in pathological fracture.
Okay.
My worry about this is a very small head. When you hammer the spiral blade in, it can push the head out. This has been documented actually. That's the reason the spiral blade has gone up from these fractures.
Okay, that is a good point. But if you see that this is a Siam picture, are you happy with the
I
X-ray?
mean, he's got away with it. He's got away with it fantastic, but it is a dangerous tool.
Okay, but we don't recommend the proximal this sort of. That's why this is not even you cannot get this in the market now.
Now there are proximal. Can you hear me, Swarnendu?
Yeah.
Again, your voice is gone. You are muted. You are muted.
Nail. Hello.
Yes.
Hello. Now there are newer version of the proximal nail without the spiral blade.
Yeah, that is there. That is the multi-lock one. So this is a I will request Professor Kaur to take this case. Urda.
Okay. As you can see, this patient is himself is an orthopedic surgeon. 59-year-old. This is the X-ray. Okay. We have already discussed and covered the imaging, so I'm not going into all those. This patient is Swarnendu has tweaked up with the background, so maybe you are not seeing this.
This is smoker, obese, and diabetic, and dominant right side.
Yeah, dominant right side, obese, smoker, diabetic. Suppose the CT scan shows you that there is a fracture involving those tuberosities, and this was fixed this way after 5 days. Post-operative X-ray, immediate post-operative X-ray. I would like to have comments from anybody. The
Calcus screw missing.
Sorry?
Calcus screw. These sort of fractures that they tend to drop down.
Comments?
Any comment on the greater tuberosity? I think the greater tuberosity is not matched with the height.
Flying up.
So it's higher up than the
normal.
Higher up than the particular surface of the head. And
so what was the problem, Professor Kaur?
I'm coming to that. We are discussing we have already discussed this, no?
Yeah.
So after 5 months, this was the problem. Pain on attempted abduction and elevation, grating sensation when the joint is moving, and difficulty in performing surgeries and some ADLs also. Not much difficulty in prescribing medicines to the patients, but that's not what orthopedic surgeons do usually. So this is the problem here. From this point, I'm shifting this to one side. Can you get back to the previous slide? Swarnendu, please. Yeah, this is a blow up of the blow up are slightly different. Can you comment on the zoomed in X-ray? Swarnendu.
The GT looks migrated posteriorly and superiorly.
Yes.
Coming to the calcar screw, can you go back to the original fracture slide?
It was probably a GT avulsion, not a.
There is no surgical neck fracture. If there is no surgical neck fracture,
okay,
still come and play.
So it was mainly a tuberosity fracture.
Calcar screw only supports if there is a surgical neck fracture. Okay, be it varus, be it mostly because it is varus, right? So calcar screw doesn't matter. This is the Siam picture on second operation. Sunit, what's your take on this?
I think the GT looks migrated a lot more medially and posteriorly. I mean, the cuff obviously
fragmented.
Slightly fragmented.
Fragmented now.
There is some loose body in the subacromial space also.
Yes, is the GT fragments have gone in there. There's GT fragments.
But not totally loose. It is, they were attached to the supraspinatus.
Can we move ahead? Go with the.
Okay, please. So after exposing, this exposure was deltopectoral. Okay, not a split. So you can see that there were no sutures through the holes in the plate. So the original surgeon, first surgeon, missed the point that those fragments were attached to the muscles. Okay, and if they are left alone, those muscles will contract and pull those fragments back and up, right, into the joint, into the subacromial space. So there was no sutures, so that's violating one of our principles we've already established, that your tuberosities are the main important things. And when we zoom in, this is the raw area under the plate. Okay. So you can see the void there. Rajiv, in this case. Swanendu?
Yes.
Unmute Rajiv, please. Rajiv Chatterjee.
Unmute is not in my hand.
Oh, okay.
Hello.
Rajiv,
Sorry.
Left side you can unmute.
What's the question?
Rajiv himself or Arnav or Dittik can do.
Yes, sir. Unmuted.
And then I'll take the opinion of Rajiv Raman also.
Yes. So what's the question?
They have played, the screws are out. So that's why you can see the yellow screws are completely out there. So Core has taken out the X-ray, taken out the plate, and the raw area under the plate. What you are going to do? Because the tuberosity is completely been absorbed, raw area there. What to do?
Basically, you have to bring your rotator, you have to bring your rotator into this hole. That is the hole. The rotator cuff has to be gradually mobilized and has to be put into this hole.
Right.
Has to be the way out. So
Rajiv Raman.
It's a calf surgery now. Shoulder surgery.
So you have to mobilize the cuff and fix it to transosseous suture.
Okay, fine.
Okay. Can we move ahead? Go, Professor Kaur.
Yes, please. So these were the fragments. These were the fragments which were still attached to the muscles. Okay.
Rotator cuff.
Yeah, it looks like
not muscles, but tendons of the muscles of supra and infraspinatus.
Yeah.
The rotator cuff. So I see double loaded anchors and margins are also approximated after desuturing. You see these anchors are quite deep, have to be quite deep because they overlie the crater. Right?
So you fixed with the anchors, metal anchors.
Metal anchors, yes, metal anchors.
I find it very difficult to mobilize these migrated, cuff, posteromedial. How any special tip on that?
Yeah, quite a long time to, bring those back into the position. Bring those back into the position by removing all those additions and mobilizing. It took a long time, yes. And
so
because
4 months.
Sorry, this is the result at 4 months. The surgeon was back to his surgeries. Next.
So this is another one case of Soumitra. Soumitra, move fast. Anything?
Another slide. Probably it has.
Any specific point to add? That only because we are maximum 20 minutes for discussion.
The point is that the supreme effort should be made to position the tuberosities and the rotator cuff in proximal humerus.
Anything, Professor Dr. Amitabh Narayan Mukherjee? Any opinion, special opinion on this? Professor Paul, you have to unmute yourself.
Hello?
Unmute. You have to unmute yourself. Professor Paul, you just put the space bar. Press the space.
Yes. Hello.
Yes. Hello.
Yes, it is a fracture dislocation. So what is the duration of the fracture? This
A fresh injury.
Fresh. So we have to open it. By open reduction and plate fixation should be done. But before that, I have to do this. In this case, a CT scan is, I think, it will be better. Okay. Yes.
So it is ordered. It is there, Professor Paul. It is there with you.
Yeah.
So surgical approach for this?
Yes, surgical approach is a anterior approach.
Deltopectoral, you mean?
Deltopectoral.
Everybody deltopectoral?
Yes.
Deltopectoral. Yes. Definitely, it is a dislocated scenario. So
yes, always.
It is best is the.
Can you tell us the technique of retrieval of the head from the dislocated position? Any special technique?
To whom you are asking, Soumitra?
Anybody wants? Ananda, you can.
Yeah. So actually, it's a fresh case. The job is easier, but in older case, that would be very difficult. So first of all, you have to just by deltopectoral, you have to identify the glenoid first. So once the glenoid is identified, then we have to see the rent through which the head is going up. Sometimes, most of the cases, it is on the anterior-inferior aspect. So we have to identify the rent first, and then gradually you have to make a space between this and between the subscapularis and also the capsule. We have to go inside. We have to make separate.
Important point is where it has gone out. You need to bring it from that.
Yeah, it is anterior-inferior. It is anterior-inferior.
Any other tricks? Anybody wants?
And if it is possible, if it is not coming up, then we have to insert a Steinman pin or a threaded any threaded.
Yes, that is a very useful tool. You put a threaded pin through the head and But don't try to manipulate too hard, because it may become loose and damage more bones in the head. But these are the tricks. You find out the hole where it has gone out and gently manipulate, milk it out, or if in a very difficult scenario, you put a
I usually sometimes when it's difficult to bring it back, I think I usually tend to open the rotary interval and try to see the head fragment as such, and then we try to negotiate the posterior border, which is actually gone anterior. If you negotiate the posterior border a little towards laterally, then probably once the articular surface faces inferiorly, usually comes back quite easily.
Okay.
In old cases, very difficult to retrieve. Sometimes we may have to do the osteotomy of the coracoid.
Yes, because there is a trick is that when you get a phrase fracture, I think you have to follow the subscap, because you have to go between the glenoid and the subscap. Then only you are in the proper place, because you have to be very cautious about the great vessels and the nerves. Otherwise, you will be in trouble. But if you're an old case, then sometimes you have to, I completely agree with Soumitra, that sometimes you have to have the coracoid osteotomy to be on the safer side.
Just one little point, if you're struggling a bit, identify the musculocutaneous nerve.
Yes. So best way to protect is the coracoid osteotomy.
Sometimes you can get away with coracohumeral ligament recession also. Just cut the coracohumeral ligament.
Yes.
So this is another one case.
Rajiv Chatterjee.
Rajiv.
Yeah.
56
so
years.
Again, your case.
This is my case.
Your case.
Okay. No, the history has been changed. Sorry, the history was changed. I got lost a bit. So actually, this is like, can I just redo the history? This is a 56-year-old lady. She wasn't pillion riding. She was actually, the actual history is she was admitted in ICU in one of the hospitals, my ex-hospital in West Bank. She was electrocuted. She was actually electrocuted, and she had standstill, ventricular standstill, asystole, revived, intubated, brought back, and they missed this in ICU completely, because she was, by the time she sort of revived, it was about 3 to 4 weeks. So I see her nearly 4 to 5 weeks down the line. This was an old case, actually. So to the panel, this is not a fresh case. This is a 5-week-old fracture dislocation, and as compared to the previous one is a posterior dislocation. So what is the plan? Okay, Sunit.
Yeah.
What's the plan?
I would like to go through the deltopectoral approach. Obviously, in the choice, my plan is to fix it. So the difficult scenario will be to retrieve that dislocated head. I think so for that, I think the advantage is already we can see the LT is separate. So we need to do the good mobilization of the rotary interval. So you need to cut the rotary interval to separate the subscap anteriorly. Then you need to release probably a little bit upper part of the pectoralis major also to retract the shaft a little bit laterally. Then you need to put traction stitches on those GT fragments, then mobilize all those supra and infra from the glenoid, the capsular attachment of the glenoid. Then once you mobilize those, you can try to milk that head gradually from the posterior pouch, or you can try to get hold of that head fragment through one of the Steinman pin, and then gradually tend to release the fibrosis around it, and then gradually try to bring it back to the glenoid cavity. Once it is there, you try to, I think it looks like there is a small beak is there on the inferior part of the head as well. So probably we'll try to reduce that as anatomically as possible and try to fix it with the
good. The only addition to your bit, I would say, lovely approach, exact approach. The only addition I did this was in these cases denude the proximal humerus also. So use a triangular space head. So cut the pec major and the lat dorsi from the humerus. So the whole proximal humerus denuded is pulled out. The lesser tuberosity is taken in front. The greater tuberosity with the suprainfestment is taken back. So I use that to go in. And be prepared in these cases. Make sure the back is free, because occasionally if it's not
milk out,
there's another incision where you go posteriorly, make a nick where exactly you put your portal in, and you go and push the head from the back also. I was ready for it. So in that case, the important thing is be ready so that the head is free floating. And that's the way it was fixed, built on. So whole idea is you have to try to fix them. You have to try to do is an extensive approach. Keep everything ready. And I had to put a threaded Steinman pin into the head to gradually free it, and then blunt Howards to free the head all round and then bring it back into the glenoid. Pitch the head to the glenoid. That's the next step. So after you pin the head to the glenoid, put because that's the rotator interval you're through, bend the pin up and then put your tuberosities together, tie them, take the pin out, put another pin through the tuberosity into the head and then fix them. And this is the end result. This is 4 months down the line.
Fantastic, Rajiv. We are moving a bit fast because we have got...
Yeah, carry on.
Because the order from the referee is that we have got 10 minutes left.
Okay,
then,
sorry, carry on.
So this is another one case. This is another one, Rajiv's case. I think Sunit is got, Sunit's case is there. This is Sunit's case, Sunit?
No, this is not my case, sir.
Okay, so so this is like the same.
Yeah, this is my case. I think this was
Sunit's case.
I think 38-year male. I think she had a fall. I think you can see that the large GT fragment is fractured. We heard that from the previous GG Corsair X-ray that most of the GT fractures need actually suture fixation. But I think in this case, I think only this was quite young and the GT fragment are only single large fragment. So I think this was fixed with 2 screws only. I think this is. So I would like to have the opinion of the panelists about the result of this, expected result of this patient. Doesn't look like nowadays.
I think after the discussion with the panel discussion in this lockdown,
we will talk.
It's a combination of soft tissue and bone fixation. Remember the soft tissue injury with a fracture.
So after
what is the expected result of this?
No. It is obviously it will be good. So that is the beauty of the surgeon. The thing is that after listening 3 proximal humerus webinars in this 3 days time, probably who is going to do this again?
That's not many will probably do it, but I think if you add these sort of fixation along with some screw, then there is no harm in doing it.
My point blank question to only Soumitra is whether you are going to repeat this operation again with this fracture.
No.
Okay. So another one case. This is I think this is another one case.
Achilles.
Achilles.
Yeah. This is the less severe case that shown by Rajiv sir. This is also the posterior dislocation.
So this is a light bulb we want to tell, no? Light bulb.
Yeah. This is other patient. This is the light bulb sign, and there is no fracture. This fracture is there.
Okay.
So go to the previous X-ray. So I have tried to MUA and close reduction, but it was reducible but dislocable, so very unstable. So CT was done in this case, but I do not have the X-ray. So what I find, there is the fracture of the lesser tuberosity and some part of the shaft also.
So
and I have
2 plates. I mean, even you have used a Harbert, no?
1 Harbert screw for the head defect. That is the reverse heel sac lesion is there.
Okay.
So I have put lesser tuberosity over the that defect and 1 plate with the lesser tuberosity, and with the other plate you can see also there is the one undisplaced fracture at the head also, at the neck also. And unfortunately I do not have Philos plate at that time because I have ordered only a Harbert screw and CC screw, and my assistant have put some 1/3 tubular plate is there, so I have utilized that.
Okay, nice one. So this is another one, 78 years female, history, fall 8 days before, COPD 88% saturation.
No, it is not my case.
This is not your case. This is the another one. This is another. You can see the displacement. This is the CT scan. This is the CT scan with head split. Ritik. Your case CT scan with head split.
Sir, this is a case. This is a 78 years old female patient with history of fall 5 days back. She was otherwise good, but having a she's having COPD with room air saturation of 88%. There is no significant any cardiac problem or there is.
But the head is 2-piece, 3-piece like.
Yes,
head.
Sir.
So who is going to fix it or replace? Who is going to fix it?
Replace.
Who, everybody replace?
Replace.
So it has been done. Hemi replacement.
No, I would have done reverse in this.
You have done reverse. So this is a big controversy. I'm not going into the fall of that trap by Sunit. So Hemi is a good option in 78. because reverse, everybody is not that skilled like Sunit. So reverse is a good option. But thing is that most of the panel, I think they will go with the hemi. So I will ask one trick I want to learn from Sunit. What is the trick? How you pass your sutures during the hemi?
I think this was mentioned very nicely by the Pascal Bailey. The first, you need to stitch your one GT fragment through the processes, and then you need to stitch your LT fragment with your, as you can see here, these are marked with the C is probably GT, you need to fix it with the processes first, then you need to fix the LT with your processes, and once these two are fixed, you need to stitch these two together on top of that, and then you need to stitch it those with the shaft as well. And at the end, I think you need to put a encircle sort of suture on top of everything through the neck of the processes. I think
so you recommend to read the Pascal's article before going to the hemi?
Yes,
no?
yes, absolutely, absolutely.
I completely agree with Sunit. The best technique is till date is the Pascal's article, how you resuture your tubers, because tubers
it's a little bit I mean, difficult to understand seeing those so many sutures, but once you read that article, things become much easier.
Yeah.
Amitabh, you want to add something? Amitabh Narayan Mukherjee, because he is the master and he has got one prosthesis in ME. Dr. Mukherjee.
Not there.
Okay. So this is another one. This was neglected 61 years. 61 years, female, 3 months. Sunit, I am going a bit fast for your sake, because we have got, the referee is signaling me that we have got only 7 minutes left.
Yeah.
So this is the CT scan. You can see the whole head fragment is fragmented and completely been out.
Yeah, it's 3 months old also.
3 months old also. So you will go to reverse or hemi?
I would like to do an hemi. 61 is quite young for arthroplasty. So I would like to do an hemi arthroplasty in this case. I would expect the cuff to be good.
So you do the hemi, this one.
Yeah.
Okay.
This is the
so this is the
hemi at 8 months follow up.
Okay. Good. So this is another one case going a bit fast. 75 years male presented 6 hours after RTA. You see the medial displacement. Do you apprehend something on this?
Vessel
injury.
So okay, so you see this is presented by Amrish Jha. This is Amrish Jha's case. This is, you can see always, if there is minimal doubt, you have to go with the CT angio. You all agree on that?
Yes,
absolutely.
Yes. Absolutely.
So he has that, and this is the way you can see that the dissection around the axillary artery. So never miss that, it can happen. This is the
arms abducted like this.
Yes, what is the question?
It was abducted arms, abducted over. That is not good for musculature anyway.
Yes.
But thing is that because in the CT scan machine, when if you go with this thing, the radiologists don't. If you don't go with the patient, they always put the patient in the Chaitanya position. It is known as Chaitanya position.
That's for the vascularity.
This is referred in some literature. I will give you the papers. Chaitanya position.
Compromised vascularity. Okay.
So this is the way they repaired, and this is the way you can see the vascular graft. This venous graft is given. So this was repaired afterwards. This is the, if you can see, this patient is admitted at Fearless. Sunit was referring to the hospital which some surgeons who are orthopedic surgeons were. As you can see from the date, it is 12/4/2020. 12/4/2020. You can see.
Lockdown.
I am quite lucky to go sometimes in that hospital. So this is the X-ray, or this is the CT angio of 12/4. This is the angio, and you can see this. The patient is came to us 29 hours after the injury. So vascular surgeon told that don't touch that guy, just wait and do repeat angio 7 days after. Then once there is no pseudoaneurysm, unless there is pseudoaneurysm, don't operate fast. So this is our opinion. Thank you. So this is the end of the presentation. So I will refer to Arnav and Ritik for the questions.
Yes, sir. There are some questions from the audience. First question, I would like to share that there is much emphasis was there on conservative treatment, KOR, chest fixation, and plating, but there is less emphasis on nailing, the multi-lock nail or the previous nailing system in proximal humerus fracture. So can you please elaborate on this one?
So multi-log nail, I think multi-log nail is a good option. Multi-log nail, you have to learn the technique. People now, they have extended. It was when it was came into the market, probably they told it is for a 2-part fracture and a 3-part fracture. Now they have extended the indication of multi-log nail even in the 4-part fracture. The basic trick of doing the multi-log nail when you do for a 4-part or 3-part is the entry of the nail is not like the old nail. It is more or less, remember, this is the most important point of the multi-log. It is more or less towards the center of the humeral head. So if you do that, on that you put the multi-locks locks there, and then you resuture your tuberosities. And the best advantage in the multi-log nail is that you can have the option of screw and screw. Another one option is that you have got the holes at the end of the bigger yellow screw so that you can tie your sutures on that. So I think that satisfies the question.
And the other question, sir, what should be the ideal preoperative radiograph? That is a varus or valgus, which can be treated with this type of multi-log nail.
Multi-log nail, or what the question?
The multi-log nail, the patient selection for this multi-log nail. Can you please?
Multi-log nail. Indications of multi-log nail.
Multi-log nail, yes.
Indication of multi-log nail. Huh?
Yes. Who is going to answer on that, or I will answer? Any ideas on multi-log nail, Sunit?
No, sir. I have not done a single.
With the multi-log nail, still a very steep learning curve. Be very careful with that. Start off simple 2-part fractures. Once you're comfortable doing 2-part fractures, then go to 3-part. Then think of your varus valgus. The experts can do any of them.
Can I say something?
Shailesh Pai has got a huge series from Mangalore. He showed us a few days ago. Some of them were really mind-boggling. I would not venture there because I am not anything beyond 2-part, just 3-part.
Can I say something, Shanundu? Can I?
Yeah.
Yes, you are not audible most of the time.
Carry on, sir.
Something is going wrong with my thing. So the only point in the multi-log is basically the entry point. You have to be very careful about the entry point of the multi-log.
I've already told that the multi-log entry is the trick.
Entry is the main thing. Otherwise, you can do it so many complicated fractures. I have a small series of around 10 or 12 of multi-logs. So it's a wonderful thing, but the entry is very tricky.
It's easy to do with the philos in 4-part and 3-parts rather than going for multi-log. That is a bit of extended indication. I don't think it's the right indication.
No, it's a long segmental, like it's a big.
Those are the indications. But
a long segmental fracture, comminuted fracture. No. Proximal is not ideally is the case. It's the long segmental comminuted fracture, and there is some associated comorbidities. Patient is not that much stable. In that case, you can do it.
Okay. Any other question?
Next question. I think we should go fast so that we can answer all of them.
Yeah.
Next question.
Fast.
There is another question that if the patient is fit for K-wiring and chest, patient will be able to do the philospating can be done in that patient also. So what will be that take on that, or the fracture patterns where the K-wiring or chest is recommended?
What is the question?
The question is, if the patient is fit for K-wiring and chest, then the philospating can also be done. So
philospating, what is the time required for philospating?
So there is a question on the YouTube.
Time required for philospating, the K-wire required only 10 to 20 minutes maximum. Okay, so some that can also be done with the help of the regional block. Okay, but philospating, that will require at least 1.5 to 2 hours.
Yes, sir.
So that is the main problem. Okay.
Yes, yes.
Next,
and associated comorbidities.
Next,
associated comorbidities has to be considered also.
Okay. Any other question, Arnav?
Yes, if Ritik have got something, there has been also a question that is there any role of a traction view in case of proximal humerus fractures?
Don't do that.
Not really.
No.
Is that don't do that?
No.
Too many major structures nearby.
Okay, fine. And if somebody has encountered inferior dislocation or subluxation of humeral head after a philosplating, and how to tackle that?
At the OT table or where?
No, post-op.
Follow-up.
Follow-up.
Post-op follow-up or the OT table. That is
Due to deltoid atony or due to weakness of the deltoid.
Rajiv is answering. Rajiv, you answer.
Yeah, there's some
rehabilitation. Yeah, please, Rajiv, please. Yeah.
No, carry on.
Yeah, you can, yeah, please.
There's a small subset of patients who have a deltoid atony after this. Is basically and I have seen it mainly if you have handled the axillary nerve. So just good physiotherapy, get them moving early. Most important thing, get them moving early. They nearly, or if you saw, I think who's Sunit's case, even him replaced the slight subluxation, it came up. They all come up within 2 to 3 weeks. They all come up.
Can I add something?
Yes, please.
Yes, Soumitra.
Now, I think if you see there is inferior subluxation, first you need to look your fixation whether you have corrected the varus rightly or not. If you have a residual varus remaining, then it will look subluxated on the posterior. So that's the first thing you need to look. Then the rest what Rajiv mentioned. So it's atony of the delta.
Next question. Any question?
Usually correct, sir.
So now I'll ask you few rapid fire questions so that I want very brief and to the point answer. So that will be considered as a take home message to all the listeners who are actually attending. So what will be the absolute indication for doing a CT scan? That what in the X-ray will say that you have to do a CT.
If I cannot interpret the X-ray.
If you can interpret that this is a two-part fracture, and if you have the proper good X-ray, both orthogonal views, and you are confident that with that X-ray that there is no head split. If you are minimum doubt, please do a CT scan.
Okay. And what is the most commonly encountered complication after a conservative management, and how to avoid that?
Because remember that proximal humerus fracture, if you read the literatures, 75 to 80% can be treated by conservative treatment. That's why we have kept so many conservative follow-up, which has been done beautifully by Rajiv. So remember, 15 to 20%, even in the world literature, they need the treatment by operative means. So if you are if you decide that I'm going to operate on that, please remember that you have to be very meticulous when you operate.
Okay.
Can I just give a supportive literature on this?
Yes.
Proffer has done a follow-up on this. 5-year Proffer is still holding same numbers. There is a study from Scandinavia, same results. The study ongoing in Brazil, they are having strict indications of inclusion criteria, huge displacements they're looking at. Results will be coming out this year, middle.
Remember, 80% is conservative. 80% conservative.
Conservative,
80% conservative. True.
Absolutely.
Any contraindication of using a Philo's plate, or any fracture can be managed by a Philo's plate?
The fracture which cannot be managed with a Philo's plate is the head split.
Head split.
This is the only contraindication of Philo's is the head split.
And what are the special fractures where we should avoid doing a deltopectoral approach?
That is when you as all the learned faculty they have mentioned that the greater tuberosity, if you find in your AP and the trans this Y view is completely backside, and also sometimes you have the Soumitra told that is the valgus impacted fracture. There you can go with the superolateral approach. Otherwise, deltopectoral is the workhorse. Agreed?
I think it's very difficult. See, the GG Corsair patient, the GT was lying posteriorly and back up to the glenoid, and he did that with the deltopectoral approach. If that GT can be brought to the deltopectoral approach, I don't think there's any GT which can be brought by the deltopectoral.
You can help a small posterior incision. You can take a help of a small posterior incision also.
That is not needed. Abduction of the arm is
abduction, extreme abduction.
Absolutely.
Who was said?
Abduction of the arm, your GT will come back.
Absolutely. Keep a separate drape trolley. Keep a separate drape trolley on the side. Bring it in, and the arm across,
keep
and
the hand like this.
C-arm across. You see it very well. I've seen a couple of cases with John. He does all of them now at the abduction. In Ganga Hospital, all of them done in extreme abduction.
Even I was listening to John's this thing. I was just interacting with John that sometimes he advocates that if you are real trouble, even in the deltopectoral, you can take off some of the deltoid from the acromion.
Absolutely.
There's no harm. There is beautiful trick is that if you are really struggling to take off, you cannot see the greater tuberosity which has gone back. You just take off some part of the deltoid from the acromion, and if you try to reach the transosseous, the result with the end result is not that bad. is not that bad. Believe me.
Because
Next.
you are preserving the nerve supply.
What?
Because you are preserving the nerve supply. That is most important.
Yes, obviously, because your whole deltoid is supplied from the back.
Yes.
So that's the beauty.
From clavicle, take out from the anterior part of the acromion, no problem.
And what is the most common complication faced after a Philos plating, and how to avoid? Any tips and tricks?
Not problem is the problem starts with the how do if the people doesn't know how to put the sutures around the tuberosities. That is the main stuff. Problem starts with that, and the height of the plate. It should be 5 millimeter from the greater tuberosity height and 5 millimeter from the lateral margin of the bicipital groove. If you follow the rule of 5, you will never mistake. And better
there are positioning of the screws as well.
Yes,
the calcar screw. The calcar screw.
We think about holding the subchondral bone. We think about holding the subchondral bone with the screws, which is very wrong. It's not required because the screws are in divergent mode, and if you go through the subchondral bone, chances are that it is over penetrating, and if there is a AVN and collapse, those screws will be remaining prominent to the glenoid.
I just want to, just before concluding, I just forgot to mention one trick, that if you do a Philos, please remember there's a beautiful article at the end of the operation. Please externally rotate to 60 degree, and then you take the proper AP. You will never miss that something is out. And the recent literature is that you have to take 9 views of the proximal humerus after fixation of the Philos to say that not a single screw is out. Most of the time it goes, which is posterior-medial, that goes out. So it has to be full circle of a humeral head so that you know. And the trick is that never drill it full. Always try to put your
woodpecker technique.
Dip gauge like what you do in your pedicular screw. So that way. And thing is that now recent last recommendation is that your screw should be 8 millimeter from your subchondral bone. Because if the head collapses, these screws are all lock screws. They will be kissing on the glenoid.
That's what I think.
Yeah.
So I think we have covered all the questions, and
on dot 6 o'clock. On dots we have finished.
So we have managed to finish in time, and so I will take the privilege to thank all the esteemed faculty and the panelists for their active participation and their cases they provide and the time they took for.
The thing is that before we go off, before we go off, Partho, our secretary, beloved secretary, he is going to comment on the, because he is going
to. We'll take message from both of our prestigious president and secretary sir. Both. Before that, I and Ritvik, I think both of us together will love to thank Dr. Swarnendu Samanto.
Yes,
and I think it will be a big clap for him, because it's like he's the key person, and we three just sit every day together in the morning, in the night, for the planning and execution, how everything should go, and it should go smoothly. And so big thanks to him for the guidance and everything. And now I will request our president sir and secretary sir to say a few words, and then we conclude the meeting.
Partho, I cannot see Chinmoy sir. Partho is there.
Yes, I am here. Hello.
Yes.
Follow.
You unmute everybody.
Yes.
Okay, it is the only thing I can say after going through the whole webinar, because while organizing this type of event, we are actually busy with other work, but it is the only time that I have with this webinar 2 hours. So I can say only one thing, that is the excellent input that we have got. I think it is the best ever webinar I have heard of. And again, it is the whole credit to the, I must say, to the AOTS. And also, I have got the first time about this webinar from Dr. Swarnendu Samanto sir. And so, with this note, I can also add something, that in this COVID situation, we are going to contribute some amount of relief fund also, but we are taking some time because we have enough enough money to donate. But the thing is that we have some as it is a long term kind of thing, so we have to wait some time, and we will communicate with our member later on. Again, thank you all faculties and for their effort, and also the young and energetic our moderators. Again, thank you all for your patience hearing and active participation. Thank you.
Our president, final comment is from president.
Yes, important and nice webinar. I've gone through all through for 2 hours. So some highlights. Most of the cases, as you have recommended, can be managed by the conservative method. And when operation indicated, most of the cases can be approached by the delta vector approach, which is relatively safe. And when you are planning for the conservative management, never use the shoulder immobilizer. It is the arm pouch, and start movement from day 1. Start with the pendulum. After 5 to 7 days, start with the assisted abduction. Then you will have the best result, because the main complication with the conservative method is the restriction of abduction. And complication, operative complication, mostly related with the medial, that is vital structures, vessels and nerves. I have seen disaster side. So take care of the medial structures when you are operating, and always try to protect the vessels and nerves by using your finger. Use no instrument, no retractor. And about the serious cases, the vascular injury, yes, it is not uncommon, and one must be competent enough to diagnose early the vascular injury. So almost this is all about the webinar, and I think most of the participants will learn a lot, and that will be applicable to their practice. Thank you.
Thank you. Thank you. Once you're off from the YouTube, we'll be just having our discussion.
So thank you. I think after wishing Shubho Novobarsha to everyone, we'll stop our stream from YouTube.